欢迎大家莅临今天的会议。
To fill out the satisfaction survey via the QR code on the badge after the keynote lectures. Lunch will be provided based on the completion of the surveys and presentation of your vouchers located in your ID bags.
第三，请将您的行动电话调整为震动或是静音，以免影响会议的进行。感谢您的配合。
Lastly, to minimize disruptions of the lectures, please kindly switch your cell phones to vibrate or silent mode. Thank you for your cooperation.
欢迎大家莅临今天的会议现场。会议即将于3分钟后开始，请各位贵宾尽早就座。以下有几点注意事项，请大家注意。
Ladies and gentlemen, welcome to the conference, which will begin in 3 minutes. There are a few reminders we would like to announce.
第一，本会场禁止饮食，午餐时间请移动到第5会议室以及群英楼1楼用餐。
Firstly, there is no eating or drinking in the auditorium. During lunch break, please proceed to Conference Room 5 or Chiying-Lo first floor to enjoy the meal.
第二，与会人员证上有满意度调查表的 QR code， 午餐将凭满意度调查表的完成画面以及识别证套内的餐券领取午餐。
Secondly, we kindly ask all our distinguished attendees to take a moment to fill out the satisfaction survey via the QR code located on the badge after the keynote lectures. Lunch will be provided based on the completion of the surveys and presentation of your vouchers located in your bags.
第三，请将您的行动电话调整为震动或是静音，以免影响会议的进行。谢谢配合。
Lastly, to minimize disruptions of the lectures, please kindly switch your cell phones to vibrate or silent mode. Thank you for your cooperation.
来为我们揭开今天研讨会的序幕。
Our conference is now officially commencing. First, we were honored to invite the chairman of Taoyuan General Hospital Ministry of Health and Welfare to give the opening remarks.
我们亲爱的执行长林庆峰林执行长，还有我们副执行长王玉伟王副执行长，还有来参加本次大会的诸多的院长那很感谢共同的莅临那我就不一一称呼了。那也很感谢今天到场的各位参加的同仁们，大家好，大家早。
早。
这一次是我们第12届的全人研讨会。那这个全人医疗研讨会是我们部立医院的一个传统，从开始到现在一直都在部立医院里头举办。那么这一次呢，我们跟桃园疗养院的邱院长这边，我们也做了一个很强的一个合作。那把这一次的全人研讨会呢扩展到国际。我们这次在线上还有一些国外的嘉宾、国外的演讲的同仁还有一些专家一起来共参加这个盛会。那我们也是非常的感动，也希望说在今天的课程里头呢，大家都能够学到满满的经验带回去。那这个全人医疗是现在政府在主推的，我们在照护上来讲，都是整合性的一个照护。那这样子的一个照护，希望能够落实在每一家医院。那这也是我们这一次办这个研讨会一个很重要的点。那这一次投稿的篇数相当多，2300多篇。那我们在论文上录取的是一半，大概1300多篇。最后在下午的口头只剩下60几篇，这应该是非常非常的精彩。那这一次大会早上会有3个主题的演讲，包括我们的灾难紧急的应变，那包括我们艾滋病的防护，还有我们一些药瘾的一些防护，这个都是跟我们桃疗这边共同合作来做的一个推动。那我就不多说，我们就恭请恭请我们的大家长我们的林庆峰林执行长来给我们勉励，谢谢。
我们所有与会的，我们的部立医院的同仁，那还有我们所有其他从各大医院，还有我们各大院校，那所有的嘉宾那今天看到我们在座的就是包含我们2个主办医院就是我们陈日昌院长跟邱宪章院长几个院长一起过来，其实我的心情是非常的高兴，那也非常喜悦。过去3年，当然疫情期间。那我们真的是也度过这一段大家在冲击，当然在这个沉潜的时候那好不容易其实已经过了3年，我们可以度过这一段我们说struggle 或是说我们在很艰辛的这个过程里面，我觉得是大家一起努力把台湾的健康把台湾的这个所有的医疗品质继续维系。那已经是12届了我记得3年前其实也是在桃园主办12代表其实是一个我们的所谓的季节的轮替，1年12个月，也是12。我们常常在我们华人说12生肖，那其实它是代表一个圆满。那当然这个部分其实我们不是看现在办了12届，其实中间是大家一点一滴大家一步一脚印把今天的成果再一次在我们桃园医院，我们所有的我们医疗从业人员我们大家的努力。当然今天我代表部里面来到这边，那原本王次长要来，但是跟他报告一下。今天就是行政院就是立法院开议然后就是会有一个这个所有的这个质询，所以王市长昨天说他没有办法到，所以代表他向大家致歉。不过 他还是说希望我们集合我们所有部立医院，我们其他所有的有院，好，刚刚我们的主持人也特别提到哈，就是我们25家部医，当然还有71家的医疗院所哈。那刚刚还有提到说很多的学校哈，就是有20多家的这个学校哦，这么多篇的这个论文哈。那我最近参加2场哈，一个这个国际的研讨，一个是在韩国哈，我们叫 ISQA 哈，这医疗品质啊。最近另外我们台湾争取主办哈，就是 IC， 就是我们的这个环境卫生哈的，还有流行病学的国际研讨会，都是70几个国家。那今天我也看到，就是我们的手册，大家都人手1本。其实我越看就觉得说，哇，好棒，很精致。其实我们的期待也是在于说，未来我们卫福部主办的这样的一个研讨会，那我们也在其他我们的有院、盟院，还有我们的这个盟校，我们一起促成，让这样的一个全人医疗的整合的这样一个国际论坛，更多被 promote， 让更多人能够看见哈，我们在这里大家一起努力哈，在这边的所有的贡献哈，所以我们也是希望啊，这个这样的一个研讨会是深入我们每一家医院。医疗品质、病人安全，特别在今年，我们特别在所谓的各年龄层哈，就是确保我们的这个健康生活跟福祉这样一个目标的里面，我们继续努力。那当然，这个我们的部医的在这一段时间，无论是我们的医疗的绩效、我们医疗品质、病人安全，我们都这个一起更多来提升啊。也我希望说，我们今天的这样一个国际的研讨会哈，不止邀请这是我们国外的这个专家学者。那也是希望成为我们在研究、教学、发展上面一个很重要的刺激跟 milestone 哈，大家继续往下一个12年再继续努力。那再次祝福今天的我们所有的大会，一切都非常的顺利，谢谢大家。
谢谢李执行长以及刚刚陈院长的支持。这次的活动有非常多的长官莅临，请介绍到的长官可以帮我们起身挥挥手，跟大家打个招呼。
There are many distinguished guests are in audience today. When introduced, we kindly invite our guests to stand and wave to everyone to greet.
首先，让我们以热情掌声欢迎卫生福利部附属医疗及社会福利机构管理会的副执行长王玉伟王医师。
Let's begin with a round of applause to welcome Deputy Executive Director of Hospital Welfare and Organization Administration Commission.
欢迎财团法人国家卫生研究院副院长陈维坚，欢迎。
Vice President of National Health Research Institute, Dr. Chen.
欢迎桃园疗养院院长邱宪章，欢迎。
Superintendent of Taoyuan Psychiatric Center, Dr. Cho.
欢迎基隆医院陈维达副院长，欢迎。欢迎台北医院郑顺平院长，欢迎。欢迎巴黎疗养院院长张介信，欢迎。欢迎乐天疗养院院长施宁浪副院长庄玉明，欢迎。哦，不好意思，乐生，不好意思，对不起。欢迎彰化医院副院长陈英正，欢迎。
Deputy Hospital Director of Zhanghua Hospital, Dr. Chen.
欢迎嘉南疗养院院长吴文正，欢迎。
The Superintendent of Jianan Psychiatric Center, Dr. Wu.
欢迎新营医院院长陈明志，欢迎。
The Superintendent of Xinyin Hospital, Dr. Chen.
欢迎胸腔病院院长王少忠，欢迎。
The Superintendent of Chest Hospital, Dr. Huang.
欢迎旗山医院院长李永恒，欢迎。
The Dean of Qisan Hospital, Dr. Li.
欢迎河村旅游医院院长徐国芳，欢迎。
The Dean of Hancheng Tourism Hospital, Dr. Xu.
欢迎台东医院王兰福院长，欢迎。
Superintendent of Taidong Hospital, Dr. Wang.
欢迎高雄医学大学附设医院王生冷教授，欢迎。
Professor of Kaohsiung Medical University, Professor Wang.
还有欢迎我们的铭传大学、万能科技大学的代表，欢迎。
And the representative of Mingchuan University and Wanmen University, thank you.
请再次以热烈的掌声感谢各位长官百忙之中抽空前来参与，与我们一同共襄盛举。
Thank you to all our distinguished guests for taking the time out of your busy schedule to join us today.
接下来，我们邀请主席、长官以及与会来宾拍张大合照。摄影师。
At this time, we would like to invite the chair of the conference and all our distinguished guests to join us for a group photo.
好，麻烦大家帮我往中间坐齐，就是旁边的朋友、后面的来宾们帮我往中间坐。对对对，不用客气，我们可以前面一点。对对对。站中间一点，后面的朋友们、来宾们，帮我往中间坐，往中间靠拢。后面的也可以往前面坐，我们坐的越前面好，看起来照片会更瘦，因为现在都有广角嘛。好，麻烦帮我移动一下，谢谢。然后帮我脱下口罩哦，露出你漂亮的脸庞。来，后面的来宾帮我尽快入座。左前方那边还有位置，那边还有位置，快！好，那我们等一下来个3连拍哦，看向前方的摄影师哈，一个是摄影大哥，还有我们的可爱的摄影师哈，来看一下前方来第一张照片哦。哎，同学帮我尽快入座。来哦，帮我脱下口罩，看一下前方的摄影师。来，3、2、1，不用一起就好了，一起。来，我们拍第2张哦，第2张我们大家比个赞。我们卫福部非常赞。来，3、2、1。来，第3张我们比个耶，好，活泼一点的，笑得开心一点，让我看到你的牙齿。哎，3、2、1，摄影师满意吗？可以哈。好，那我们进入下一个环节。这次的活动呢，分为3个阶段。啊，大家移动了。今天的议程将分为3个场次来进行专题演讲，最后会进行 Q&A 的时间，让贵宾与台上讲者一同进行交流。
Today's schedule will be divided into 3 sessions for various lectures revolving around 3 different topics, ending in a Q&A segment in each session. This will provide our esteemed attendees with the opportunity to engage in dialogue with the speakers on stage.
首先，我们第一个专题演讲的主题为健康风险预测与管理及卫生因应准备措施。
The theme of the first session of our keynote lectures is strengthen the prediction and management of health risks and the measure of medical contingency.
我们非常荣幸邀请到医福会副执行长王玉伟医师来为我们主持，欢迎王副执行长。
We're honored to have Dr. Wang, Deputy Executive Director of the Hospital and Social Welfare Organization Administration Commission, as our moderator for this session.
王副执行长为前卫福部花莲医院代理院长，现任于卫生福利部台北医院眼科顾问医师。
Deputy Executive Director Wang was the former superintendent of Hualien Hospital and currently serves as a consultant ophthalmologist at the Taipei Hospital.
Well, our Honorable Executive Director Lin and our host Superintendent Chen and all the superintendents and honorable guests. Good morning, everyone. In the beginning, I want everyone to be a little bit patient because I'm told that I have to speak in English. So back to the topic. The first topic is about the health contingency and the risks. So we invited a famous speaker. It's a Professor Tricia Greenhalgh from the University of Oxford in the Department of Primary Care Health Science. You can see in the book she is very famous and major in many great researches and get a lot of grants and published around 400 peer-reviewed papers. So we invited her, but her it's a pity that she can't be here personally, but she offered a video clip talking about from EBM to EBM Plus, learning from the experience of COVID-19 in the United Kingdom. So maybe she cannot hear our applause, but we still give him a welcome, make the opening. So is the video ready?
Learning from the experience of the COVID-19 pandemic in the UK. Now, I'd like to start by thanking you for inviting me to give this talk, and also to thank my research team, my support staff, my PhD students, my university, the people I collaborate with, and my funders. So thank you to all those people. I'm going to talk you through an example from the UK and also from more widely actually Europe, a little bit from the United States and the World Health Organization, but mainly I'm going to be talking about UK policy around the question of should we wear masks? And of course, fundamental to that question is the first question on this slide, is the SARS-CoV-2 virus airborne? What's the evidence for that? And I'm going to take you back to the 8th of March 2020, when a rather lovely concert happened in a big concert hall in Amsterdam in the Netherlands. It was a Bach concert, lots of singing. And out of a choir of 130 people, 102 of them became infected with COVID and 4 people died. 1 person in the choir and 3 partners of members of the choir. So this is a tragedy, and when I saw the news item about this, I thought to myself, this virus must be airborne. There's no other mechanism of so many people getting infected in one indoor concert. So this is the kind of story that convinced me. But it didn't convince the World Health Organization. On the 28th of March 2020, the WHO put out a tweet saying that it was fake news that the virus was airborne. In fact, they said COVID-19 is not airborne. They were very adamant that it wasn't airborne. And much more recently, on the 23rd of November 2022, the WHO's chief scientist, Dr. Soumya Swaminathan from India, left the WHO. She was leaving after being there for all through the pandemic. And she was asked what her biggest regret was. And she said, my biggest regret was we were not forcefully saying this is an airborne virus. I regret that we didn't do this much earlier. So the question I want to ask really is why did the WHO get it wrong? Why were they so convinced that this was not an airborne virus? Now, just to remind ourselves about the mechanism of transmission, if a pathogen is spread in droplets, in coughs and sneezes, it will fall to the ground in those droplets, because the droplets are pulled down by gravity. And so actually it doesn't spread much within, much beyond 2 meters. But of course, if a pathogen is airborne, it gets into the air and it will spread much further in an indoor space. The UK, in their prevention policy for COVID-19, started off and continued and still today are using a droplet model, which we now know is flawed. And they still give heavy emphasis to hand washing. There is no evidence that hand washing prevents the spread of COVID-19. It's a very good thing to do, but there's no evidence it will stop the spread of COVID. Cleansing surfaces, no evidence for that either. Physical distancing, staying 2 meters apart, that does have an effect preventing the spread of COVID, but that's probably not because of droplets, it's probably because airborne transmission too happens mostly within that close 2 meters distance. Face shields would protect you against droplet infection, but there's no evidence that they protect against the transmission of COVID. Isolating only of coughing and sneezing is not an effective way of preventing this virus from spreading because, of course, it spreads sometimes from people who are asymptomatic because it's breathed out in the air rather than, or maybe in addition to coming out in drops. And finally, wearing a waterproof mask only within 2 meters of people with symptoms, we know that if that's the only time you wear masks, it doesn't help very much because the virus is in the air. Some countries, and I think Taiwan is one of them, have policies for reducing transmission of SARS-CoV-2 that were built around an airborne mechanism of spread. And I suppose the first thing to say about airborne transmission, and I think you probably know all this, is that people may be asymptomatic but contagious. So you can go into a room, you can go onto a bus, nobody's coughing, nobody's sneezing, but there might still be virus in the air. And it follows, therefore, that we have to take a different approach to prevention. We have to limit the time spent indoors, especially in crowded places. We have to ventilate buildings or filter the air. We have to maintain physical distancing when indoors, but that isn't the only thing we need to do. If we're going to be really serious about preventing transmission, everyone should be wearing a well-fitting respirator mask while they're indoors, and avoid indoor singing. This is a problem, of course, if your job is an opera singer, or you know, if you're working in a school or something like that. It's not fun to stop the singing, but actually, from the prevention of transmission perspective, things that release the virus into the air include heavy breathing, shouting, singing, vocalizing. So we have to restrict those when there's a lot of COVID about. Now, back in March 2020, after I saw this tragedy of the Amsterdam concert, I set about writing an article with some colleagues saying that we should wear face masks. This would probably not have been controversial in Taiwan, but it was very controversial in the UK. And what we said in this article, which was published on the 2nd of April 2020, is that we should use the precautionary principle. And what that means is we don't know yet, there is no definitive evidence, but we think it would be a good idea for people to wear masks, just in case. Nobody did, not for a while in the UK, but we put our marker down, and actually I became very unpopular in the UK. I got a lot of trolling on social media, people writing rude things about me in the press, and things like that. Out in the Western world, in USA, for example, masking was not popular. For example, in September 2020, Scott Atlas, who at the time was President Trump's COVID-19 advisor, he is a doctor, he was sure that masks don't work, have no effect. And he is citing, in this tweet, he's citing a number of very authoritative sources, the World Health Organization, Professor Carl Hennigan from the Oxford Center for Evidence-Based Medicine, so he's based in the same university as me, but we don't agree on this, and the United States Centers for Disease Control. They were all saying there's no evidence that masks work. Now, this is now 1 year later. This is in March and April 2021. And on the left is a view which we might call the EBM view, the standard evidence-based medicine view. And they had been commissioned by the World Health Organization, Carl Hennigan, Thomas Jefferson, various others. They'd been commissioned to review the evidence as to whether SARS-CoV-2 was airborne. And they said no, it wasn't. I was very worried about this, and so I got together with some other scientists, and we wrote a paper which was rapidly peer-reviewed and published in The Lancet, and it was called 10 Scientific Reasons in Support of Airborne Transmission of SARS-CoV-2. And we used this technique of EBM+, which I'm going to tell you about. So if we use standard conventional EBM, the answer comes back no. If we use EBM+, we find the evidence that actually this is an airborne virus. So let me explain what the difference is. Here is conventional evidence-based medicine. Evidence-based medicine says there's a hierarchy of evidence, and systematic reviews and randomized controlled trials are at the top. And then below that, there are other forms of evidence, but they're not such good evidence. And so if you're being very narrow in your interpretation of EBM, and not all EBM people feel like this, but if you're a narrow EBM practitioner, you say we only really want the top level of evidence, that red triangle at the top, we want to find the randomized controlled trials. And because that's better than all the other trials, we can ignore any other evidence. And that's exactly what they did. So Hennigan and Jefferson from the Oxford Centre for Evidence-Based Medicine just took that top triangle of randomized controlled trials. And you can see they, at the time, this is back in 2020, evidence from 14 trials on the use of masks versus no masks was disappointing, showed no effect. And you can see this picture I put there of them putting the rest of that hierarchy of evidence into the trash can. There was no need to even look at it, and they didn't look at any of the other evidence. Now let's look at the EBM Plus approach. What EBM Plus says is, yes, randomized controlled trials are the best evidence for testing the efficacy of a drug. I am a cancer survivor. I'm only alive because of a randomized controlled trial. I'm very glad they did a randomized controlled trial to test the chemotherapy, the surgery that I had to cure my cancer 8 years ago. That doesn't mean that a randomized controlled trial is the best evidence for any question that we ask. And particularly when we're trying to ask the question, how does this disease happen? How does the intervention work? A randomized controlled trial is not a very good design. EBM Plus also says we must explain all the evidence. We can't simply say, well, that evidence is not randomized controlled trial, so we can ignore it. EBM Plus includes randomized controlled trials, but it also includes laboratory studies, real-world case studies, and any other study design that is relevant to the question that you're asking. Let me show you a few. Here's some real-world evidence. This is a study by Christian Leffler and his colleagues. They're based in America, but they looked at many countries around the world. And what they're looking at here is the first 100 days of the pandemic in each country. So day 1 for each country is the first documented case of COVID-19. Let's start off with the blue line and the orange line at the bottom of this graph. And you can see that the blue line is countries that introduced masking of the public by 15 days. And the orange line is those that introduced masking between 16 and 30 days. The non-mask countries are countries that didn't introduce masks until beyond 30 days. Many of them didn't introduce masks at least for the first 100 days. And there is a very, very dramatic difference. You in Taiwan, in the first 100 days, had 29 deaths, you probably know that, Vietnam 44, Hong Kong 210. Tiny numbers of deaths compared to the countries represented in the red line. In the UK, 128,000 deaths. USA, 610,000. Brazil, 450,000. So many orders of magnitude more deaths in the countries that didn't introduce masks. Now, the EBM purists will say, well, it wasn't a randomized randomized-controlled trial and all sorts of other confounding variables. I agree. This is not in itself definitive evidence of the value of masks, but when you look at this paper by Leffler and his colleagues, you find that every single country where people started wearing masks very quickly had very, very slow transmission of COVID-19. Let's look at another kind of evidence. Here is some laboratory evidence of ferrets. And you can see here that the ferret in the bottom cage has COVID, is coughing and breathing out the virus into the air. And then these cages, the ferret's cages, are connected by an air duct. And that's the only connection between those cages is that air duct. And you can also see that it goes around corners. So the droplets are not going to go around corners, they're going to hit the walls. And all the ferrets in the top cage became infected very consistently in these experiments. And it was published in Nature and demonstrated, I think, beyond any doubt that something was traveling in the air between these two cages. Other kinds of evidence. Here's another laboratory study where you video someone sneezing. This was published in the New England Journal of Medicine, and it demonstrated that when someone sneezes, a big cloud of suspended droplets will travel a very large distance. And so the idea that we only need to stay 2 meters away was actually, and this is actually done before the pandemic began. So there are these laboratory experiments already published in leading scientific journals. On the right of this slide is a real-world case study of another choir that got infected, actually. There were 60 members of the choir and something like 50 of them became infected. I think a couple of them died. Again, early in the pandemic. And unlike the Amsterdam concert, this was one where some scientists went along and interviewed everybody. They asked every single person, where did you go? Did you use the toilet? Did you stay the whole time? Did you eat any of the sandwiches? All that kind of thing. And they were able to do a very detailed case study of this unfortunate tragedy in the American choir. Now let's come back to this question, is SARS-CoV-2 airborne? If you take a narrow EBM view, ideally you would like some randomized controlled trials. I'm not sure what you'd randomize, but they certainly wanted them. But if you can't have that, say, the EBM people, we need to directly isolate viable virus from air samples, and we need to show direct infection of humans from sharing air. So very linear, direct requirements. And as far as they were concerned in April 2021, they didn't have that. So they said there's no evidence. The EBM plus argument is that there's plenty of evidence that this virus is airborne. For example, the super spreader events, as I've shown you with the choirs, asymptomatic transmission, that the virus is transmitted when there are no droplets. The fact that the virus is transmitted many times more easily indoors than outdoors suggests that something's going on in the air, because a droplet would have a similar effect, whether it was indoors or outdoors. The ferrets in cages. Air sampling does sometimes show viable virus. It doesn't always, because it's very, very difficult technically to isolate live virus from the air. Air filters. If you look at an air filter, for example, in a hospital, you can actually identify live virus sitting in the filter. And finally, that hospital-acquired COVID is greatly reduced when mask-wearing policies are introduced in those hospitals. So that's some of the evidence that we put in our Lancet paper. The Cochrane collaboration commissioned Thomas Jefferson, Carl Hennigan and colleagues to do an update of a systematic review, and here it is. This review only looked at randomized controlled trial evidence. They didn't try to explain why the ferrets got sick. They didn't try to explain why the people in the choirs got sick. And they came to the conclusion that there was no evidence that masks work. So this is now 2023, and they are still saying masks don't work. The New York Times published this piece not long ago, saying the mask mandates did nothing with any lessons we learned, and Thomas Jefferson from the Oxford Center for Evidence-Based Medicine is quoted in here as saying there's just no evidence that masks make any difference. Full stop, he says. Actually, the editors of the Cochrane review, the Cochrane collaboration themselves, rather than the authors on the review, had to issue a statement saying actually they did not show that. They examined whether interventions to promote mask wearing help. In other words, they studied randomized controlled trials of mask mandates, but they didn't look at the rest of the evidence. So the editors of the Cochrane library wanted to distance themselves from these very strong statements from Dr. Jefferson. There was a lot of publicity here. Forbes had an article in March 2023 saying the Cochrane editors say the review does not show that face masks don't work. And the reason was, they explained this, the paper mixes together studies that were conducted in different environments with different transmission risks. It also combines studies where masks were worn part of the time with studies where masks were worn all the time. And it blends studies that looked at COVID-19 with studies that looked at influenza. So after the publication of this Cochrane review with its very confident statements, masks don't work, there was then a backlash. Oh, masks do work, and it wasn't such a good review after all. Well, let's summarize. Do masks work to reduce SARS-CoV-2 transmission? The narrow EVM view is still saying, and they said it in the Cochrane review, we've only looked at the best evidence, they said. They said there's 78 randomized controlled trials, and that makes any non-randomized trial evidence unnecessary. They said there's no statistically significant effect of masks on measured primary outcomes. Therefore, masks don't work. But the EVM plus community is saying something quite different. They're saying there is overwhelming evidence that SARS-CoV-2 is an airborne virus, which means that an effective filter would have to defy the laws of physics not to work. Only 3 of the randomized controlled trials in this Cochrane review actually tested masks in COVID-19. The rest of them tested other interventions, or they tested them in influenza, etc. So we're talking about 3 trials, not 78. And there were major methodological flaws in 2 of those 3 randomized controlled trials. And the 3rd trial did show an effect. The impact of masking increased in a dose-response way with compliance. The more people wore the masks, the less transmission there was. So in general, the reason why the masking doesn't work is when people are not wearing the masks rather than the masks themselves not working. And then there are many, many real-world studies of mask mandates which demonstrate that they do work. Now, we published this paper in a journal called BMJ Evidence-Based Medicine. We said that evidence-based medicine must adapt or it will die. We said the pandemic has made the shift from EBM to EBM plus even more urgent than it already was. So I'd like to thank you for your attention. I'm sorry I can't be with you
Well, I'm glad to see most of you are still alert. So thanks for the great speech of Dr. Trisha Greenhall. It tells about the EBM plus, means EBM plus lab data, plus real world data, and other things. So we may keep the questions in the end of the session. And so we will invite our second speaker, Dr. Xu. And we all know that Dr. Xu is famous in the disaster medicine. And she got the medical degree and the PhD degree in the National Taiwan University. So he is the senior alumnus of me. And she shared a lot of hospital safety and about fire, about earthquake to me and to all of you. I think many hospitals have received the lecture from the Dr. Xu. And talking about sharing, he is the first resident in emergency medicine in the National Taiwan University. Maybe she will tell a lot about his personal experience. So let's welcome. 欢迎我们的这个史主任，大家的好朋友。
Thank you so much for inviting me here to share my experience. After a very wonderful speech about COVID-19, that's now we come back to a quite fundamental safety issue, talking about the patient safety and the environment safety. In the past 3 years, we suffered from COVID-19. In Taiwan, in healthcare facilities, quite safe. But in the other country, a lot of hospital was burned because a lot of alcohol-based hand rub, oxygen tank. For example, a fire in Iraq kills about 90 patients and staffs, and a lot of fire in India, and every fire kills about 20 casualties, including patients and healthcare providers. So it's a very important issue to think about the environmental safety in healthcare. Especially during recent several years, due to climate change, a lot of weather-related disasters like typhoons, flood, sometimes hospital got flooded and out of electricity, and the medical care discontinued. And 2 years ago, Ukraine and Russia has a war, and people in Taiwan think of if we had war or civil riot, what should we do to cope with that? So I think that's talking about the fundamental safety issue about fire. So today I would like to talking about the emergency preparedness, not only emergency medical preparedness, but emergency preparedness because some engineer issues, some policy issues, we have to focus on that. And the emergency preparedness for healthcare facility, because it was not just a hazard in hospitals, but also in nursing home and the long-term care facility. I would like to talking about some lessons we learned and what we should do for moving forward. And I think the story for me start from a fire about 15 years ago. There's a fire in the operation room in the winter night in year 2008. During the day, it was not so late, about 7 o'clock in the evening, and a light in the storage room, our operation room, initiated a very, very small fire. It's a wooden plate, and then the fire sparkling dropped in the storage room. There's some alcohol, so initiate a huge fire. During the day, there's 2 people under surgery in the operation room, and several minutes later, there's a lot of smoke in the operation room. Finally, a patient died on table during the operation because there's no medical care, no life support for at least 40 minutes. And the smoke spread all over the buildings, the east building of our hospital, and more than 1,000 patients were evacuated out by themselves because they escaped from the buildings and they go to the ground floor and going outside. And a lot of doctors and the nurses try to find their patients. And before that, before the moment that we got fire, the hospital was qualified in all kinds of inspection before the fire. And for medical accreditation is okay, for fire accreditation is also okay. But it's a very dangerous situation. And after that, I have been assigned as the fire marshal for the hospital for 9 years, and so I have to make many revision for the hospital. And after that, I visit at least 100 hospitals in Taiwan, and I find there are many things in common. If we do not pay attention on that, the next hospital will got fired. We did not know what hospital will occur, but we are quite sure there will be one. At the day, the electricity shut down, so it's all in black, and a lot of medias are going outside. A lot of firefighters rush into the hospital. They try to find which way to go into the operation room and where to doing search and rescue jobs. The patients going down to the ground floor, and they try to find medical care. For example, these patients, they got surgery for their lungs. They have a chest battle. He tried to find a mosquito to clamp the tube, but he cannot find one, and we also cannot find one. And for example, in emergency room, there are a lot of smoke. And several years later, 4 years later, there's another healthcare facility fire in Tainan, and it kills 30 people. It was a nursing care facility in a hospital. In year 2018, there's another fire, also in healthcare facility fire, a nursing home in a hospital, and killed 50 people and 37 injured. So in conclude that I find every 6 years we will have a hospital or a healthcare facility fire that kill people. So after that, now it's about 5 years. So be careful. Maybe the next one is waiting for us. And because all these hospitals are all qualified in all inspection, before that, no one can predict there will be the fire. There's no major mistake in the hospital preparedness. So I think there should be some systemic factors behind that. And as my experience in fire marshal in a hospital, I have to say, in my country, I think the rules for fire safety, they did not think of the healthcare facility. They just, the rule is designed for theaters, restaurants, bars, and the KTV because they are dangerous places. Hospital, nursing home, they are also dangerous places. So we use the quite similar rules, regulations, and the practice drill every year. But during fire in hospital, we cannot do the similar thing. For example, if you have dinner in a restaurant, you heard the fire alarms. The rules say we have to stop dinner and going outside until the firefighters search the place and then everyone can come back. Okay, it's good. But in hospitals, if you have fire alarms, everyone should go in outside. And after we check everything and then come back, and you will find your patients in ICU and in operation room, they all died. Because we cannot do it the same thing in a theater, in restaurant, in bars, and the KTV. In hospital, in nursing home, in long-term care facility, there should be different regulations, different design, different policies. There's a lot of technical engineer issues about that, but I think today I want to go back to some fundamentals part. Okay, for patient safety issue, we also we think of the hardware, software, environment, and the livewells. All the policies focus on software, livewells. So we want to teach everyone to learn how to put out the fire, the use of fire extinguisher, and every hospitals should be checked for their emergency response plan. But we forget the hardware and the environment. The healthcare facility personnel did not familiar with their hardware and the environment. Also, the engineers, the architecture that designed the hospital, they do not know what we did in hospital, in nursing home, because they just design a building like a hotel, like a restaurant, but they use as a hospital, as a nursing home. So it's a discrepancy between the safety requirement and the provider. Okay, for example, there are several major discrepancies. For other business, they are usually in the open space. You go into the room and you can see every table. But in healthcare facility, they are usually in small compartments. Not just for privacy, but also for infection control. So they are small rooms. So it's very easy to make it like a maze. Very easy to get confused. In huge hospital, we get confused. But in small hospital, we also get confused because they are small compartment. The second, for other business, usually open to the public, to every people, or to every personnel within the business. But for hospital, it was not the rule. For example, the operation room fire in my hospital, many firefighters, they do not get into the operation room. They do not know how to get into the operation room because they are not taught to do that. And we discourage people to go inside because they will interfere with the infection control. So during the day in fire, they do not know how to get in the operation room and they cannot put out the fire. So a lot of places in healthcare facility are restricted. The second thing, many multitasking in healthcare personnel. In our system, if we had a file, everyone should stop their daily work, and someone to put out the file, someone to alarm, and someone to evacuate patients, and someone has to have safety restriction and the safety control. Because in restaurant, in movie theater, in KTV, we can do that. You do not want to keep on your dinner during fire. But in healthcare facility, we cannot stop our daily work. So in the operation room, because the scrub nurse was assigned as a fire extinguisher at the moment. If we go out to put out the fire, what we should do in the operation room? Every medical care stopped. So the system cannot have a very simple and rude system. 防火管理. So the continuity of operation is very important, but we do not know that. And the fire department, the firefighters do not know that. We invite the firefighters to teach us what we should do during fire. And I think their thinking is stop everything, put out the fire, and then come back to your work. But it did not work. The third thing is the command structure in healthcare facility are very complicated because we have to provide our medical care. So we have to understand who is the patient's attending physician, who is charged the nurses. But during fire, there's a very simple instant command structure. And these two systems, there should be some coordination between that. The patient's care responsibility and the emergency response convention, there are some contraindication, there are some conflict between the two systems. The fourth thing, the victims are handicapped. In a restaurant, people, most of them, they can walk, they can run. But in hospitals, people cannot walk. Sometimes they even do not have consciousness, so they cannot see anything, they cannot hear anything. So we have a lighter down, we have a lot of signage on the wall, but the people within the healthcare facility cannot follow the sign, cannot follow the alarms because they cannot read that. Another thing, in our fire regulation, we said if a fire signal occurred, there should be a fire alarm, and we cannot stop the alarm. The alarm is very, very loud. And the loud sound urged the public to take action, to evacuate out. But in healthcare facility, we need very quiet space to promote our communication. And sometimes a lot of warning signals, they informed us through the sound. For example, the vital sign, the blood pressure is too low, oxygen saturation decreased, or the ventilator disconnected, the pressure too high. And we heard the signal, different signal, and we know what to do in the next moment. But during louder fire alarms, we cannot hear that. So the patients, many patients was killed during evacuation, during discontinuity of evacuation rather than killed by fire. And the second, we cannot communicate between staffs and the patients. I talk to my nurse on what to do, but because the alarms are too loud, so we cannot communicate. So everyone doing their own way. We cannot communication, and we have to guide evacuation activity, and the directions is a big challenge. So some professors in fire department, they also think during emergency, after you take actions, we have to stop the alarm. But in local government, they also say you cannot stop the fire alarms. And a lot of hazardous materials in healthcare facility. For example, I just say in COVID-19, a lot of hospitals got fire and kill a lot of people because they have many oxygens, high pressure tanks, and flammable liquid like alcohol, alcohol hand-based rod. And the NBC type of hazmat, for example, nuclear medicine, and a lot of toxins. And the filters and the ventilations in hospital are very complicated. For example, current regulation require every hospital to shut off the ventilation if you have fire alarm. But at the moment, the negative pressure, they stopped. Positive pressure in operation room or in pharmacy also stopped. So it's a major infection control issue in hospital, but the government did not know that. Okay, the interruption of patient care may kill people. For example, the hydrant, a lot of water gush out, and in ICU, the electricity went out at the first moment, and the patient will be killed. So if you use water hydrant, it's very, very dangerous if patient's still there. And the disconnect of vital supply during moving. I just say because we cannot hear the alarm. So if the tube disconnect, we can understand that, and it will kill people. And some medical gas bulbs, the shutdown is very important to damage control, but also will kill patients. And the fire extinguisher may kill patients. For example, the fire in operation room, if we use ABC, the powder fire extinguisher, the patient later will die of infection because a lot of powders within the operation room. But currently, they are still require we prepare ABC type of fire extinguisher in operation room. While in the US, the NFPA 101, they require in the operation room, there should not have any one ABC type of fire extinguisher. So I think the regulation is behind the requirement. And in MI department, if you use a regular fire extinguisher or use a axe, and it will like a bomb and kill everyone in the past. It's very, very dangerous. So we cannot use that, and the fire extinguisher should be special designed. And there's a lot of conflict between safety guidelines for different hazards. We focus on fire, but I think in hospital, a lot of people die of suicide. More people die of infection control, infection spread. But the regulations between these three, there are a lot of conflict. So for different inspection, we have to say in different ways. this week we have fire inspection, we say in this way. Next week, for the suicide prevention, we talk in another way. And some doors we opened because of fire inspection. The next week, we close the door because of the suicide prevention. It's clear. So I think we have several things to do. I think for the researcher, I think what is the basic hardware requirement for safe hospital, how to make an easy reading and a workable emergency operation plan, what kinds of command structure is more efficient and more competent, how to make everyone know what we should do in disaster, and the education and the training programs, drill and the exercise. I think I have 3 solutions. The first one, comprehensive inspection of facilities, hardware, and the emergency operation plan. I think we start from the high-risk area, considering the medical care and the patient characters, and the staged, revised, and the retrofit. We cannot step the hospital, tear down all the hospital, and then rebuild one. It's impossible. So we have to check that and plan a staged division. I think different buildings need different prescription. For example, our hospital, the West Campus, in year 1920 and in year 2007. I think they are different design. They need different fire safety policies. The solution to simple, reasonable, and the systematic emergency operation plan. If you have 100 units in your hospital, every unit, I think at least 10 pages. So your emergency operation plan will be 1,000 pages. It's very easy. So it will be a very mass density document. But the rule behind it should be very simple, reasonable, and systematic. Make the other personnel very easy to understand, because they have to learn many other things: patient safety, infection control, and their surgery, medical knowledge. The third solution, practical and pragmatic disaster exercise education. I think fit their true environment and the daily practice. Well designed and conduct disaster exercise. Make them understood their hardware and the software well, rather than a heroic action. And especially I do not like a religious ceremony. I saw a lot of fire drills is a religious ceremony, 宗教仪式. And finally, I think because there's a lot of threat ahead of us, so I think we have to prepare for the worst and hope for the best. There's a sign in President Kennedy's desk. It says, "Oh God, the sea is so great and my boat is so small." In confronting our fire, I think within hospitals, I think we are very tiny and we are very weak. So we have to think of, we have to prepare for the worst, and we can provide the best result for our patients. Thank you for your attention.
Thank you, Dr. Xu. Like I just said, we also always learn a lot from Dr. Xu, and he is always love to share with us. Talking about fire, we just one tragedy happened in the early morning in Wanhua district in Taipei City. I think many of you maybe seen the news, and our executive director has remind all the superintendents to look for the safety in our hospital. So back to the session, now it's a QA time. And regarding most of you are from Taiwan, so Chinese Mandarin may be allowed in the questions. 我们也开放中文提问，谢谢。 Any questions? Right.
Yeah, it's a very fantastic talk. I'm Yizhen Wang from Taipei Hospital. For the first speaker, I'd like to know that because EBM, after the pandemic, EBM shift to EBM plus. But how many studies or which kind of studies should we choose to include into the EBM plus for us to the meta-analysis to get a final conclusion? Yeah. And the second question is for the second speaker. For the fire, what is the difference between the hospital and other industries about the risk assessment and risk management for fire in the hospitals? And can you share us any information technology to tackle these problems and difficulties in hospitals? Thank you.
Well, thank you, Dr. Wang. First question, do we get line with Professor Tricia? No? So maybe I will focus on the second question, Dr. Xu.
I think for the second question, in the past 50 years, I pay more of my efforts to educate our boss, to spend money on that, the first thing. Because the boss was saying, okay, we fulfill all the requirements, what we should do something extra. Okay, so, but today I think it's very to educate our boss because a lot of terrible story, the first thing. The second thing, I think it's very difficult to persuade our policy maker to improve the regulation system. You know, they are very reluctant to make more requirement for the hospital, because all the hospitals say, oh, we lost a lot of money, or the economic in medical care is not good, so we cannot put more money on the facility. I think there's another issue. The third is also very difficult to persuade the fire department that our environment is totally different from your thinking. It's totally different. They also, if firefighters in a local fire station, they go to your hospital, they just teach you very similar to response to a resident. That's what they learn, because they are just focused on put out the fire. But you are not only put out the fire, you have to keep the patients alive. So recently, in 3 ways, I try to promote their concept about that. And the first is to teach the architecture and the designer what we need in the hospital. What they think of the hospital is very similar to the television show in 乡土剧. In hospitals, there are still tea bottles on the table, and the patients just only with the oxygen mask and the then tie. It's totally not the story, but the architecture still think of our hospital is very similar to that. They did not have any concept about the medical gas pipelines, the storage or the operation room, intensive care unit, support system. So I think through these 4 ways, we need to improve our healthcare facility safety. And finally, I get a PhD degree in public health school. I was very interested to find in our health management college, they did not teach any issue about that. Am I wrong? We're talking about the financial management, health policy making, and how to improve your medical care quality. But we do not talk about the environmental safety. So I think in 5 parts, we need many things to do. Did I answer your questions? No, I don't think so.
Thank you, Dr. Xu. I don't know, is there any president of a university here? Thank you.
Thank you for Dr. Xu's very inspiring talk. I have 2 questions. One is you talk about, hospital is different from like a restaurant, right? Because you have patients. But now I moved to the National Health Research Institute. We have animal center. Those animal centers are very important. So, so my question is the fire department now already preparing some specific guideline for those specific facility? Or for example, you say, in an MRI room, you need different kind of fire extinguisher. My question is that kind of special fire extinguisher available now or no? And so I think it's very, because as a society moves on, it's more complicated. And the second question is, because I was former dean of College of Public Health, the environmental safety of the hospital now belongs to the new department. It's called Occupation and Environmental Health. And it's regulated by the Ministry of Labor. So I think in the future, they need to put this into their curriculum. Thank you for your reminding.
Thank you, Director Chen. Before Dr. Xu answer the question, I want to repeat the question from Dr. Xu. Did you teach fire extinguisher in the school about health management? Health management. Did you see, Dr. Xu, did you just ask to teach fire extinguisher in the health management school in the university? Okay, Dr. Xu,
because my teacher is here, so I cannot comment about the health management. But I also teach in School of Public Health. I had a class with Dr. Ma Huimin, and we're talking about emergency preparedness. And in that class, I teach that. So in the School of Public Health, we do that. But for a lot of engineering issues, we have to do that. We need more, because we have to teach the public health practitioner to understand that more detailed issues. And I think for the first questions, I think nowadays many hospitals, they understand for MRI, there should be different kind of fire extinguisher. For example, in Taoyuan hospital, it's okay. In Taipei hospital, it's also okay. But the government did not say that. And the fire in operation room, many hospitals, they do not use, they use the carbon dioxide extinguisher. In Taipei, New Taipei City, is also okay. But in some other prefectures, the fire department require us to use the powder extinguisher. So we know what we should do. Some government, they understand that, but we did not put in the regulation or in laws. So I think many hospital teams come from different prefectures. In your local fire department, they require you doing the wrong way, but you cannot against them. That's why I say the policy making and have a more reasonable rule is very, very important. So my answer is also yes and no.
Thank you, Dr. Xu. Any questions? Regarding of time limit, so maybe we'll end this session, and so next session we'll begin and take a rest for 5 minutes. Okay.
谢谢。接下来为5分钟的休息时间，这边提醒各位贵宾，请抽扣填写与会人员证上面的满意度调查表 QR code。午餐将凭满意度调查表的完成画面以及识别证套内的餐券领取午餐。
Now we have a 5-minute scheduled break. During this time, we kindly remind all our distinguished attendees to take a moment to fill out the satisfaction survey via the QR code on your badges. Lunch will be provided based on the completion of the survey and presentation of your vouchers located in your ID bags.
会议即将开始，请各位贵宾尽早就座，并请将你的行动电话调整为震动或是静音。谢谢你的合作。
Ladies and gentlemen, the conference will resume shortly. Please take your seats and turn your mobile phones to vibrate or silent mode. Thank you for your cooperation.
相信大家听完第一场的演讲都意犹未尽。接着，专题演讲主题为“终结艾滋的流行”。
The theme of the next session of the keynote lectures is End the Epidemics of AIDS.
我们非常荣幸邀请到桃园医院精神科医师苏博文苏医师来为我们主持，欢迎苏医师。
We are honored to have Dr. Su, a psychiatrist at Taoyuan General Hospital, as our moderator for this session.
苏医师为前桃园市政府卫生局副局长，致力于身心健康行为推广，深入社区，落实全人关怀，在学术研究上已有非凡的成绩。
Dr. Su, formerly the Deputy Director General of the Department of Public Health in Taoyuan, is not only highly accomplished in academia, but also dedicated to promoting mental and physically well-being and engaging with the communities to implement holistic care.
Okay, ladies, gentlemen, and the distinguished guests, welcome to the second part of the conference, End the Epidemic of AIDS. I am the moderator, Po Su. And we know there is a goal of 95-95-95 proposed by UNAIDS. The number of HIV-infected people in Taiwan has declined for 5 consecutive years. It was the only made possible by the cooperation of many units. Today, we have the privilege of delving into the understanding of toward elimination of HIV infection by 2030. What are the challenges? A snapshot from Melbourne, Australia, a fellow fast-track city. Our distinguished speaker for this session is Ben Yu, MD, Director of Prairie Market Clinic, Australia. Please join me in giving a warm round of applause to welcome Ben Yu onto the stage.
Thank you very much. Can you hear me? Is it better? Thank you. Yes, that's better. Thank you very much, distinguished guests. I'm very honored to be asked to deliver this talk. And thank you very much for Dr. Cheng and the organizers of this conference for inviting me. So my name is Dr. Beng Yu. I grew up in Malaysia and I work in Melbourne. I've been working in the field of HIV for over 25 years now. As you might notice, my name is Beng is actually a Hokkien name. My father's Hokkien. Anyway, to start with the talk. So the title of my talk is about towards eliminating HIV, which we're all trying to do by 2030. What are the challenges? And I'm using Melbourne, Australia as a comparison. I think there are a lot of comparisons between the two cities that are relevant. So as was said before, there's UNAIDS, this was about 2014, set up the target of 1990 to help end the AIDS epidemic. So this was the goal initially. By 2020, 90% of people living with HIV will know their status, and 90% of people diagnosed with HIV will be on treatment, and 90% of those people will have a viral suppression, undetectable viral load. Since then, there's some additional targets because, of course, we've gone past 2020, so there's a target of 95, 95, 95 by 2030. And this concept of these are the fast-track targets. And both Taipei and Melbourne have signed on to fast-track, which means that the governments have actually signed on for an extra commitment to actually try and achieve the 95, 95, 95 targets by 2030 to try and end the HIV epidemic. So comparing our two cities, in Melbourne, it's actually Victoria, actually is the whole state. Currently, in 2020, the figures were 90, 92, 96, and in Taipei, 88, 95, 95. So we're all just a little bit short of that target at the moment, but I think we're all at similar stages. That's why I think some of the things we talk about are relevant for both our cities. So just a quick background history. HIV in Australia, I think same as a lot of countries, very high cases initially in the 80s, came down a little bit in the 90s, and then has sort of been stuck in Australia. It's about 1,000 new cases per year from the mid-2000s till, let's say, 2016, 2017.
since 2017, if you look at this map, since about 2017, the numbers have actually dropped. And a lot of the drop has actually been in gay males, male-to-male sex, where the numbers have dropped significantly. And as can be seen, so the same thing doesn't apply for heterosexual populations, where the rate of HIV infection in Australia has remained very similar, but the numbers are very, very low in Australia in this population. And this again showing that, the notifications about 2017, you notice a significant drop since then. Obviously, at this end is probably partly the COVID effect as well, so numbers have dropped partly because of COVID, and we're waiting to see if the numbers will come up a little bit again. And this is the care cascade. So in Australia, there's an extra step. So looking at from 2017 to 2021, people who are diagnosed with HIV, 88% to 91%. So we've done a little bit of improvement then. We usually have an additional indicator in Australia, which is people who are retained in care. So we've done a few surveys, checking to see if people are still in care, whether they're going to clinics or hospitals. So this is an additional measure we do. And receiving HIV treatments, you can see that it's been about the same. And suppression of viral load has been about the same as well. And this is just comparing to the targets, where we're actually just falling still just a bit below the targets. So this is nothing new, but the World Health Organization has talks a bit about guidelines. So what's important to ending HIV is prevention, testing, treatment, and service delivery. So these are the focus of what the World Health Organization says. Firstly, about prevention. So in Australia, I borrowed this from another state, from Sydney. There's a lot of talk about ending HIV. ACON is the New South Wales AIDS organization. And these are the things that they're promoting in terms of prevention. Condom use is still relevant, PrEP, undetectable viral load, and PEP as well. We'll talk about this in just a little bit more detail. So all about condoms. We can't forget that condoms are still a very effective HIV prevention tool, so we still need to talk about that. PEP is post-exposure prophylaxis. People who are exposed to HIV can have treatment within 72 hours, which reduces their risk of contracting HIV significantly. Undetectable viral load. This is something recently that we focus a lot on. So basically, this concept of U equals U. If someone with HIV has an undetectable viral load, they cannot transmit the virus. Hence, the virus won't get transmitted to someone else. So this whole concept of U equals U has been promoted a lot in the last few years. A lot of the initial studies showed that anyone with a viral load of less than 200 copies per mil can't transmit it. In actual fact, the figure is actually higher than that. So generally, even if someone has 300 copies per mil, they can't transmit the virus. There's been no cases known about it. So this is a really important tool. If people are on HIV treatments, they can't transmit it. So it will help end the transmission of HIV. And this is what we used to say is treatment as prevention. Treating people with HIV will prevent the virus being spread to other people as well. What about PrEP? So for us, PrEP is a game changer. So PrEP is people who are taking preventive HIV treatment so that they protect themselves from HIV. So it's a daily pill that protects you from HIV. In Australia, PrEP was actually approved in 2018. And if you notice, and this is the uptake of PrEP over the years, and you see it's a very high uptake right from the beginning. And the numbers now are running that, so past 12 months, so 36,000 people have taken PrEP within the last 12 months, this as of April 2022. So PrEP is really something that's been taken up a lot. And as everyone knows, that the cost of PrEP now has reduced significantly, so it's quite affordable. And in Australia, it's also paid for by the government. But if you look at this map, where the drop in HIV actually has been from like 2017 onwards, and there's a good reason for that. Before PrEP was formally approved in 2018, all the big cities ran really big PrEP trials, as they call it. It's just to help people get access. So even though PrEP was approved in 2018, everyone started taking in 2017, which is why there's been a significant drop. There's also a topic of sexually adventurous men. What we really mean is that people who use, example, chemicals or drugs when they're having sex as well. I think Dr. Cheng will talk a bit about this because they will obviously have other challenges for actually HIV prevention in this population. What about testing? So in Australia, these are the things we have, rapid point of care testing, which I think is available everywhere, which you get results in 15 to 20 minutes. Not all the tests are antigen antibodies, some are antibodies only. Standard point of care, which is what we've been using for a very long time, where our results probably arrive within 2 days. At-home kits, which in Australia has just been approved for the home testing, and RNA testing, which requires a lab. So these are the options we have currently. But with all the testing, we need to be aware that there are certain differences. With the nucleic antigen antibody lab test, we still say the window period is 18 to 45 days. With the rapid testing, the window period is actually much longer. And in particular, the antibody tests, which only test for antibodies, the window period is longer. So it's important when we're doing counseling that people are aware that there is a difference between the different tests. What about treatments? This is a quick summary, treatments over time. So the first treatments we had were the nukes and non-nuke, as they call it. And these type of drugs stopped the HIV changing from single-strand RNA into a double-strand DNA, so it attacks that part of the cell. The next lot of medications we had were probably the protease inhibitors, which blocks the replication and dissemination of virus particles. Next lot was actually entry inhibitors, which are attachment inhibitors, like T20 as they call it, or CCR5 inhibitors, which is Maraviroc. This group of medications are very effective, but actually they're not used much anymore for lots of different reasons. And the most recent ones are the integrase inhibitors. And these have proved to be quite a bit of a game changer for a lot of people because they're very, very well tolerated and very, very effective. But then this is what's coming. So apart from all that we already have, I'm not going to go into detail, but there are also different things. There are lots of monoclonal antibodies being developed, capsid into new classes of inhibitors. So it's a lot of development of HIV treatments that are coming as well in the next 5 to 10 years. Hence, these are all the medications available, medications single or combination tablets as well. And I suppose this is probably the most commonly used antiviral in Australia, Biktarvy, which is a combination of 3 drugs in 1 pill, which showed to be highly effective. This is probably still the main drug people use in Australia at the moment, as well as Dovato, which is a 2-drug combination. So in the last few years, there have been some new 2-drug combinations, which have been shown to be just as effective as the 3-drug combination. So we've talked about prevention, we've talked about testing, we've talked about treatment. So what are the barriers? So first, you talk about access to HIV education. So even in Australia, there's a lot of effort to educate a lot of different groups of people about HIV. And I think not everyone will access this information. For example, specific groups, people in living in rural environments might not have access to this education. In Australia again, ACON, there's all this online education people can access, but they need to know about it before they can access it. ASHM is the Australian HIV Medical Association, and they provide a lot of HIV training for like doctors and GPs. So there's a lot of active training going on, same as Vital, which is another body that does that. This slide is from the HIV education department. So in the education sector, they're trying to make sure that people get taught about HIV and AIDS as well. If someone can't afford it, how can they get testing for HIV for free? So in Melbourne, there is a clinic set up called the Pronto Clinic, which is a peer-led program. So it's not actually, it's not health workers doing the testing, but peers actually doing the testing. People can access this testing for free. They can just book in and have a HIV test. They don't need to have insurance or Medicare. There are some sexual health centers around Australia as well, and there are very similar clinics all over. So there's systems set up for people who can't afford testing. This is about the needle syringe program in Australia, which is all over Australia. There's a very strong needle syringe program. In Australia, needle syringe programs were really important in the early days of HIV prevention because they were set up really early Basically, Australia managed to avoid HIV getting into the injecting use community, hence into the wider community. So they're really important. There's measures like, the PrEP prophylaxis now is spread into general practice. So any doctor, general practitioners can prescribe PrEP. They don't need any information or training. There's all these guidelines that have been published, including this one, which give people enough information to prescribe PrEP. So it should be quite freely available. And this is our clinic. So we're a general practice actually. Paran's actually in a suburb in Melbourne. We actually are sort of in the mezzanine floor on this very old historical building. And we've got 11 doctors, 9 of us are qualified to prescribe HIV medication. So not just PrEP, but for treating HIV, plus other people associated as well. Post-exposure prophylaxis. So if someone's been exposed and they take medications to prevent HIV, there are systems in place, but nowadays, because GPs can prescribe PrEP, sometimes people just prescribe PrEP as a replacement as well. And obviously there are guidelines about treatment as prevention like we talked about before. So one of the things I want to talk about too is that in Australia, one of the things that we do use, which is different to a lot of the world, is that HIV care is provided by a lot of GPs. So I work in a general practice. And in Australia, only about 50% of people living with HIV will get their care from a hospital or sexual health center, and 50% would get them from a general practice like our clinic. So clinics like ours exist in most major cities. There are usually a few clinics like that in each city. So we actually see a lot, like our clinic looks after about 1,100 people living with HIV. So in Australia, prevention is the field of health departments, education departments, community organizations, needle syringe programs, outreach programs, and all GP type services. PrEP is available to all doctors and health services, including all GPs. The PEP program, the post-exposure prophylaxis, is available from some clinics and hospitals. Our clinic can do it as well, but it's not as widely available. Testing is available everywhere, including peer-led programs, so you don't have to be even connected to a clinic as such. HIV treatment, so this is where we're different. So we have GPs. There's a system called S100 registration. So we need to do a training course, and then we need to do continuing education every year, and then we're allowed to prescribe HIV medications, which are usually for infectious disease specialists. And yeah, so 50-50 split between sexual health centers and hospitals and GPs. So what are the other barriers? So this is UNAIDS. AIDS update talking about vulnerable populations where sex workers have 4 times the increased prevalence of HIV, people who inject drugs 7 times, gay men still 11 times, and transgender people 14 times. This on global things. And I think in addition nowadays there are migrants, refugees, asylum seekers, which provide a challenge as well for certain parts of the world. This is again, this is talking about the success of in Australia, where the needle syringe programs are very effective in actually doing HIV testing and management. But even in Australia, I'm putting this up because one of the other areas I deal with is anabolic steroids. And in Queensland and New South Wales, 2 of the big states in Australia, they beefed up their laws about steroids. So possession of steroids is actually illegal as well. And it makes it harder to actually promote people actually accessing care because of making it more illegal. Sex workers, I didn't even know this until the recent HIV conference, that there's still some states in Australia where sex work is considered illegal. So again, they can't always access care easily. So there's a lot of effort now, like in Queensland, which is one of the states which still has illegal sex work, where they're trying to actually make sure it's at least decriminalized so that sex workers feel free to come forward and get information, testing, and treatment. What about this is something just happened in the last few months in Australia. Medicare is our national insurance system, which gives us access to treatment and testing and health services to some extent. And finally, in Australia, they've actually approved that people without Medicare, there's a system in place where they can get HIV treatment and care as well. So they're not excluded from the health system in terms of HIV treatment. Oop, it's jammed, hang on. The slides are jammed. Okay. Okay, good. And this is just a slide from Australia talking a bit about vulnerable populations in Australia, which they're worried about. You know, people from Africa, low engagement health services. Southeast Asia and East Asian women as well. I know this in Australia, that's a bit of an issue. I know they're finding that there are quite a few students who are testing positive for HIV, so they've targeted some campaigns with them, especially the men who have sex with men as well, and the students I was talking before. And again, this slide again is just talking about the groups where, you know, they need to target on, you know, people born in Southeast Asia and people born in Latin America or the Caribbean as well. So there's specific groups where HIV testing and information is probably not getting to. And also in Australia, the STI rates, which include HIV in our own indigenous communities, you know, I think we're not doing very well in that regard as well. So this is just talking about, you know, what the recent changes. About 18 months ago in Australia, there was approved long-acting cabotegravir and rilpivirine for HIV treatment. So in Australia, it's approved for use, so people can come in once every 2 months and have 2 injections, and that's the total of the HIV treatments. For some people, that's a real bonus, not having to take tablet every day. So I think it's a useful thing to have different ways of looking at it. And also, this is a study in San Francisco looking at the use of the long-acting injectables in a very difficult population. So people are thinking about ways of using injections for people who might be homeless, a problem with substance use, sometimes people who are incarcerated as well. And actually being able to deliver this treatment to those populations where an oral tablet every day hasn't been a very useful thing to do. But I think this is the big thing now we need to talk about. You know, I think with what we're doing up to now, we've achieved probably 90 goals, and to bump it up to the next level, I think discrimination is a big issue. And there are lots of articles that have been written last few years about stigma and discrimination in the health facilities, and HIV discrimination is a really big topic now for discussion with a lot of people. And you can see from this, you know, stigma is a powerful social process that characterized by labeling, stereotyping, and separation. It causes discrimination, and discrimination is basically unfair and just action towards that individual. And I think this is something we need to be aware of. And I think in all our different societies, there are different people who are being stigmatized or discriminated against, and it exists in different ways. And these are different ways. I found this on, this is a Harvard Medical School slide actually, talking about different levels of discrimination, whether it's from your individual, whether it's interpersonal between people, from the community you live in, institutions, and from the whole society. And looking at where the community is, I think that's what's important for some of those groups we talked about before. You know, for in Australia, it's like African migrants, you know, discrimination within their own community, it makes it difficult for them to have a HIV test or get treatment. We have people coming to us, for example, from African communities who don't want to access any services in their own community, and they might travel like an hour away to get to us, where they know that they won't come across anyone else from their community. And again, you know, some nice slides from the CDC in the US talking about what stigma actually does. You know, it creates a big wall and barrier towards testing, treatment, safe sex, treatment and care. So it becomes a significant thing. And I think, you know, the details of this is what's different in all different societies, but these exist everywhere. And this is what we're talking about. I know even now the community groups are talking about HIV-related stigma discrimination. The whole effort of U equals U is to help actually reduce discrimination and stigma for people living with HIV as well. And there are some papers that I said about evidence for eliminating this as well. This is another slide, which again just gives more detail about, you know, internalized stigma, substance use, psychosocial health, might be issues that actually impact on individual stigma. But then you go to the larger level, which is community level, which is, you know, by their own friends, by behaviors, by family members, and then bigger things, you know, at least in Taiwan and Australia, at least same-sex marriage is legalized. That helps a little bit, I know, but HIV is of a different issue as well. Police brutality and all this. So you can see even very simple things by friends and family. And I know a lot of people, even friends who are living with HIV, find it very difficult because people might hear negative things that are said by friends, by health facilities, health workers, not knowing that this person is living with HIV, and that becomes a stigma for them as well. So we need to be careful how we actually address this. And this is just a very quick rundown for, you know, in a lot of the world, LGBT people are still criminalized, as you can see in all these sections, including where I was born in Malaysia. And also prostitution, obviously it's still very illegal in a lot of parts of the world, which makes it difficult to promote some of this information to them. So I think these are things that can reduce stigma, giving information, building activities within organizations, participatory learning, contact with stigmatized group. I think, for example, in terms of HIV, if people knew that someone that they know might be living with HIV, they might be less likely to actually say negative things. I suppose that applies for LGBT population as well, about the whole promotion of same-sex marriage. And empowerment and structural policy change needs to happen as well. And I think the conclusions I was going to say was really that we really have the tools to eliminate HIV today. As I say, we've got testing, you've got prevention, you've got good drugs, you've got PrEP, we've got everything else there. But access and equity to education and healthcare is important, and not everyone has access to this. And we need to look at where these things actually become a barrier in our own society, which is we need to target the special populations that I mentioned before, and we need to reduce stigma and discrimination within these groups and in our own communities. So just a quick finishing off. This was from, I think, from Bangkok, where they try and talk about Zero Discrimination Days. And in Australia, there are a lot of promotion about ending HIV, using this as a concept for people to think about. And there was this study that was actually presented at a HIV conference in Brisbane recently, talking about eliminating HIV. The headline is, a study in Sydney has said that they've virtually eliminated HIV. The detail is actually just in central Sydney. There's an area in Sydney where a lot of gay men live, and there are very few new HIV infections in that area. But then it does show that, it can be achieved with some of the things we talked about. Thank you very much for your attention.
Okay, thank you, Ben Yu, for your excellent and inspiring presentation. We know there are still some barriers, including HIV stigma, mental health issues, and substance use. Next, it's our honor to know more about harm reduction program for HIV positive patients with same-sex drug use. Our distinguished speaker for this session is Jianyu Chen, MD, Director, Department of Infectious Disease from Taoyuan General Hospital. Please also join me in giving a warm round of applause to welcome Dr. Chen.
Good morning, ladies and gentlemen. Dr. Ben from Australia talked about the big picture about HIV infection. I think from Australia and Taiwan, we have already achieved the goal 1990, but for next goal 1995, 95, and 95, I think it could be a big challenge. In math, I think the difference is only 5, but the 5 means will be a big challenge. And today I will show all the audience the small picture in our hospital, Taoyuan General Hospital, how we have done for harm reduction in the special population of men have sex with men, as well as injection drug user. And WHO from United Nations announced published this data in 2020. We know substance abuse is still a problem since a long time ago. And we can find out this figure, the number of substance drug abuser is increased year by year. And you can tell from the blue, blue bar, the percentage of drug user disorder, it takes around 10% of every year. And leading substance abuse could be marijuana, followed by opioid and amphetamine. And this number still keep the big picture and big number from every country. And this figure, I think we can show you the difference between countries. We can tell from North and South America, cocaine is the leading drug of substance abuse, but from Asia and Europe and Russia and Southeastern Asia, the leading drug could be amphetamine and methamphetamine. And Australia is cocaine. I'm not correct. Maybe I can ask Dr. Ben later. And the substance abuse takes quite a long time ago. This paper was published 26, but it told the story about the substance abuse since 1994 to 1998. The target population is MSM in San Francisco in United States, and the leading substance abuse is alcohol in about 25 years ago, followed by marijuana. And in Taiwan, we have also published similar data. This study was published by Professor Guo in Cheng Kung Hospital. And the study was conducted about 10 years ago. It is a cross-sectional study. It is an online survey about the MSM in Taiwan. And they found the population in total around 1,000 participants, and 2/3 used the internet to find out a partner, one-night stand partner, and about 40% they will use a mobile phone to find out a sexual partner. And among those, the population, they use 30% of them use recreational drug, including amphetamine, methamphetamine, and other marijuana and other drugs. And according to this study, and they found compared to computer-based internet, that use those using mobile app, the majority of them are HIV positive, and they would use recreational drug, including methamphetamine. And this data, this study was published, by our Dr. Chen. They published in 2020 in Asia Pacific Chemsex Symposium. This data was we collected the number since 2010 to 2019. There are totally around 3,400 episodes about the recreational drug user. We connected this data and analyzed the STI disease was reported to our CDC system. We found those recreational drug users, they have the problem such as repeated STI, and the leading STI is syphilis followed by gonorrhea. And it seems that this trend is increasing year by year. You can see from 2010 to 2019, the number increased from 48 to 471, so increased about 10 times in terms of syphilis. And the majority of the population was the age from 25 to 34. We can find out the numbers increase almost 10 times as well. Summary, we can find out the STI. Syphilis is the leading STI for total other bacteria STI disease, followed by gonorrhea, and then acute hepatitis C is one kind of STI. But we can find out the one peak over here. Began in 2040, and this outbreak of acute hepatitis A ended by 2017. I think this outbreak is quite amazing. You can say it's almost the biggest outbreak in the whole of the world. This outbreak from Taiwan CDC, there are total around 3,000 cases reported acute hepatitis A. In the report, they found especially for men who have sex men and HIV positive patient, they reported acute hepatitis A. So acute hepatitis A is one kind of STI, but Taiwan CDC ultimately launched a program of Hep A vaccination, so we can find out this outbreak ended by 2017. Up till to now, I think we hardly find out acute hepatitis A among men who have sex men, because majority of them are all vaccinated. And also, we can find out the difference among drug user and non-drug user. The difference about repeated syphilis. If those population use substance abuse such as amphetamine or marijuana, they would be diagnosed syphilis again and again, and these numbers is significant. The difference is about 12%. And this is the story about HIV positive injection drug user in Taiwan. We have the program harm reduction. It was launched in 2003. Since 2003, until now, we can find out the incidence rate of HIV positive injection drug user. Each year, I think it was reported less than 50 cases by now. So the harm reduction program among injection drug users is quite effective. And there are totally three main components. And the first one is information, education, and communication. Especially for injection drug user, we have to provide the knowledge and teach them how to prevent HIV infection and other diseases such as hepatitis C. And the second, a syringe exchange program. The injection drug user can exchange the used syringe to clinic or hospital or even pharmacy. They can exchange clean syringe to prevent the next outbreak of hepatitis C or HIV infection. And third component is a methadone maintenance therapy. And the Taoyuan Hospital, and we cooperate with Taoyuan Mental Hospital. They provide a methadone replacement therapy. So those HIV or positive or negative injection drug user could stop the heroin abuse. They can exchange to methadone. And this study was not published yet, but is conducted by Taiwan CDC. They call this is a questionnaire collected in 2018, and there are totally about 124 personnel participated in this study. We can find out all 100% of them are male, and the mean age are 32. And majority of age is between 20 to 39. They have the problem of substance abuse, and number one is methadone amphetamine, followed by MDMA, and a few of them use marijuana and ketamine. And they, before they come to this program, psychiatric exchange program, they provide psychiatric mental support and peer group support program. And before they they come to join participate this program, we found out they have the problem of substance abuse. They use those recreational drug about 1 to 6 times per week. And after they participate in this psychiatric exchange program, we can find out that they self-report they reduce the use of substance about amphetamine. And after they reduce the substance, we can find out syphilis was diagnosed less than before. About 6 months ago, they participated in this program. And also, we can find out HIV virus undetectable rate is increased from 72 to 77, and it was significant. And also, we find out another benefit. Some of unemployed rate decreased from 33 to 22, and it also is also significant. We hope we can have such a program about infectious disease and psychiatric cooperate program and peer group, and I think we can support and assist more HIV patients. They have the problem of substance abuse. And here is the data was published by London and Britain. The cohort AUR-AH2 it was quite famous. They also present such data. After those HIV negative MSM, they joined this peer group from 2015 to 2018. We can find out they reduced substance abuse from 31 to 11 percentage. It was quite significant. They also find out the bacterial STI decreased as well, but condom-less anal sex didn't decrease significantly. So today is our finding. It's quoted by A. Wiesel. The opposite of love is not hate, it's indifference. So today is our conclusion. From global estimates, the number of substance abuse is still increasing, and especially methadone and especially amphetamine and marijuana. And recreational drug use was quite important, and important fact cause syphilis and other STI among HIV patients and men who have sex with men. And second, we have a special program to provide chemsex user and also a peer group and the cooperation between different specialists such as infectious disease and psychiatry, and tailor a better harm reduction program in Taiwan. Thank you.
Okay, thank you, Dr. Chen, for your excellent speech. Under undetectable equals to untransmittable, we would like to our patient living with HIV having better care quality. Our last distinguished speaker is the second in the second part is Dr. Do from Chimei Medical Center in Tainan. He would like to share online for the topic challenge towards improvement in the quality of care and the elimination of HIV in Taiwan. Please join me in giving a warm round of applause to welcome Dr. Do. Okay, Dr. Do, please. Okay, Dr. Do. 他听得到吗？ 声音没出来了。
So everyone, can you hear me?
Okay, we can hear now.
So that's great. I'm Dr. Gary Do from Taiwan, and it's my pleasure to share with you with the topic of challenge for the to improve the HIV care in the quality of care and elimination of HIV in Taiwan. So thank you for the introduction, and so sorry I'm not at the scene with you together. So I will share the topic online. And I'm actually an infectious disease doctor, and I'm also intensivist. So right now I'm working in the ICU of General Medical Center. So regarding the HIV care in the past, due to the advancement of antiretroviral therapy, we have reached the era of U equals to U. I believe that Dr. Yu and Dr. Chen have already introduced the concept of undetectable viral load equals to untransmittable. Actually, this is a very great advance in HIV care, and it can help us to decrease further new infection of HIV, and with the drugs control, we can also prevent the development of AIDS in people living with HIV. So in Taiwan, due to implementation of the policies, including the harm reduction, the treat all policy, and also the propagation of pre-exposure prophylaxis, the PrEP, PrEP, right now we have a decreasing number of new infection, but we also have about 35,000 people living with HIV right now. So regarding the 95-95-95 target of the WHO, we have already reached the 90-90-90 in 2020, and right now, at the end of 2022, Taiwan have reached the goal of 90-95-95. So we are quite close to the target of 95-95, which is the target in 2030. Compared to a global 86, 89, 93, we are doing quite good actually in Taiwan. However, despite a great improvement in HIV care, there are still gaps in HIV prevention, diagnosis, treatment, as well as the quality of life of people, and we also have a gap in the HIV stigma. So I would like to share with you about several challenges that we might have to face in the future regarding the HIV care and control. The first is, how can we fill in the 95-95-95 gap so that we can achieve zero transmission and zero AIDS-related death in the near future? Actually, in Taiwan, we have a very comprehensive HIV care, not only for the people living with HIV, but also for them who test negative. We can provide HIV prevention, including PrEP, condoms, harm reduction. However, how to link to the care? There are several points of entry. Actually, we have a widespread testing, including the healthcare facility, public health sector, community center, as well as the NGO. We also have an HIV self-testing for the people at home. But despite the HIV testing, there's a lot of them in everywhere. There's still a very high percentage of late presenter at diagnosis. This is data from the Taiwan CDC. I would like to draw your attention here is that there is, in 2022, there's almost 40% of them who diagnosed to have HIV are presented late. That means that they already have the opportunistic infection or might present with a low CD4. So if we ask them, why are you come here so late? I think the low self-awareness of risk is the main problem. Most of them, about more than 70% of them feel that they have no risk of getting HIV infection. That's why they are not come here to get the test. And some of them don't know where to get the test, and some of them might be afraid of a positive result or even the HIV stigma. So I think the low self-awareness of risk is probably a big challenge for us to fill in the gap. And on the other hand, low awareness of the risk of infection of the population might also result in the hesitancy of taking unnecessary preventive measures to protect themselves, including the PrEP, pre-exposure, and the PEP, the post-exposure prophylaxis, even condom use. Actually, PrEP is a very effective way to prevent HIV infection in high-risk population. But in Taiwan, right now, we have more than 4,000 people adopting PrEP as a preventive measure for HIV. However, I think this number is a bit underestimated, but it is still away from the high-risk population. So I think how to increase the self-awareness of risk is a big challenge for the people at risk to access to HIV prevention care. There are still several barriers for the PrEP adoption, including that they need to pay by themselves. It is not covered by the insurance, and there are still some gaps and barriers for the people to access to PrEP or PEP. So, however, we keep updating the Taiwan guideline, including that we also have a long-acting PrEP in the future. So this is the new Taiwan guideline posted this year, and we have an education class tomorrow in Taipei and Kaohsiung for those who have interested and to know about HIV prevention and PrEP. You are welcome to join us tomorrow. And the third challenge in the future, I think, is the co-infections. It includes the sexually transmitted infections, viral hepatitis, and a recently outbreak of monkeypox pandemic. So I think these diseases, they share a common root of transmission, and some of them might get infection together. For example, hepatitis B, hepatitis C. I'm not going to dig in for each infection. I'll just give you some examples. For example, in 2015 and 2017, there's a HIV hepatitis A virus outbreak in Taiwan, and among them, there are more than 30% having HIV. So I think there's a common behavior and the route of transmission in between these infectious disease. So even the COVID-19, during the COVID-19 pandemic, if you have a people-and-people connection, you are not only getting the sexually transmitted infection, but you can also get COVID-19 as well. So how can we prevent and treat the co-infections in this population is the big challenge, because we have emerging infectious disease like monkeypox. But fortunately, we have a lot of preventive measures such as vaccination. Like this year, we are encouraging people to taking the monkeypox vaccine. So I think it is a very important issue in taking care of the HIV population. And the fourth point is chemsex. Okay, so I believe Dr. Chen have already introduced to you what is the situation right now in Taiwan regarding the chemsex culture. And of course, we have a lot of the program is ongoing and helping the people for the chemsex rehabilitation. And I just want to give you a number, is that this is the research, this is the data showing that when the people getting the HIV diagnosis, about 10% of them have a recent using the substance in the recent 3 months. So that's why during the HIV care, we need to discuss with our clients about the substance use, and of course, if they need further transfer to psychologists or for the chemsex rehabilitation, yeah, we need to keep going with the process and helping them to deal with the problem. So in this year, we also have an Asia Pacific Chemsex Symposium, which will be held in this October, just before the Taipei Pride. So for you who have interest, you are welcome to join the symposium as well. So actually, right now in most of the clients we're taking care of are quite good in taking the pills. So actually they have a good compliance, they are relatively healthy, but actually they are aging population, just like us. Okay, so how to live a life in healthy way is a big challenge for every one of us. I think it's not only for the people living with HIV, but for every one of us. So in the era of U equals to U, I think the health-related quality of life will be the next target we're going to achieve. It's not only viral suppression, it's not only undetectable, but how can we help all of us to live in a life with good health-related quality? So there's some data showing that actually for the people living with HIV, as they get aging, so they have more incidence of comorbidities. This is the data from National Taiwan University. So it's this is quite amazing. Like if you have more than 50 years old, there's about more than 50% of them have at least one comorbidities, including hypertension, diabetes, or even high dyslipidemia or cancer, etc. So for clinicians or infectious disease doctor, how can you take care of these comorbidities together? It is not easy. At the same time, we need to measure in the patient-reported outcome. We need to know what is the quality of life. We need to discuss about the health and lifestyle medicine. We need to do the cancer prevention, vaccination, deal with the mental health issue. So it is not easy. So that's why we need more doctors or more healthcare team to help us to build up a multidisciplinary holistic care team. But there's a big challenge to build out such a team is that HIV stigma. Right now, even in a healthcare facility, we are still facing a problem of the HIV-related discrimination. This is one of the questionnaire we do in 2019, 2020 in my hospital. There are 35 of the respondents have ever saw or heard any discriminative words and behavior towards the HIV infected clients. So it is a big number. So a stigma will prevent the clients to come back to the hospital, to keep going, taking care, taking the pills, or they are unwilling to come to the healthcare center, or even right now we have a lot of clients that refuse for taking care by the dentist, etc. So how can we reduce the healthcare stigma and build up friendly hospital will be the challenge in the healthcare facility in Taiwan. So in my hospital, we're trying to having a project inviting our superintendent and all the chief of the department, including dentistry, anesthesiology, emergency care, intensive care. Then why we invite them is to let them know that actually HIV is not a scary disease. If the client taking the pills with a good compliance, they have an undetectable viral load, they are not going to transmit the disease anymore. So there's nothing to scare about. So once we can achieve the friendly environment, we can build up a team, they can have taking care of every issue, every health issue of the clients. We have more opportunities to help them to achieve a good quality of life. And I really appreciate Dr. Shen for his great project in the Taoyuan General Hospital, helping the clients to know how to change their behavior, to build up an ideal lifestyle using a project. So this is what I'm going to conclude, that actually life is not only about antiretroviral therapy, but also sharing life. So Taiwan actually is on the path towards the eliminating HIV. We are quite good in achieving the target of WHO 95. We are quite close to the target, but there are still some challenges that we need to fill up, including the gap of the 95, and the 3C care. I have already introduced to you like the co-infection, chemsex, and comorbidities. And we need to increase the awareness for the people to uptake the HIV preventive measures, including PrEP. And there is still a gap in approaching to decrease the HIV-related discrimination. But also there are still some at-risk population we need to discuss about, including adolescents, new immigrants, but there are still a long way to go. There are issues in resource, policy, legal, society. How can we engage the community, and how can we educate the general population? So I think one day we will achieve the goal, the HIV elimination, and on that day there will be no more new HIV infection, no more people will die from the AIDS, and there's no more stigma and discrimination against HIV. So thank you for the opportunity to share with you, and I'm Dr. Gary To from Chile. Thank you very much.
Thank you, Dr. To, for your excellent and inspiring presentation. I would like to thank the three speakers for their valuable insight and the experience regarding how to end the epidemic of AIDS. I'm sure we've got a lot to take away today. Maybe we have some question for the three speakers, but due to the time is delay, I think I will have to call it end now for this session. Thank you.
谢谢专家带给我们的精彩演讲。紧接着第三场的专题演讲主题为物质滥用与酒精成瘾预防与治疗。
Next, the theme of the keynote lectures is strengthen the prevention and treatment of substance and alcohol abuse.
我们非常荣幸邀请到桃园疗养院管理中心主任王主任来为我们主持，欢迎王主任。
We are honored to have Dr. Wang, an attending psychiatrist and a director of the Center of Quality Management at Taoyuan Psychiatric Center, as our moderator for this session. Thank you.
Thank you. I'm honored to host this session. Now we move on to the Sustainable Development Goal of Taiwan, strengthen the prevention and the treatment of substance and alcohol use abuse. Our distinguished guests, medical professionals, and ladies and gentlemen, I'm Dr. Wang from Taoyuan Psychiatric Center. Because of a delay for 30 minutes, so I will encourage our three speakers next session to reduce the time to present. And briefly, in order to have our lunch with relaxing time. So now I'm honored to present you first Professor Zhiqiang Lin, the associate neurobiologist at McLean Hospital in United States. Let's give Professor Lin a big applause. Thank you, everyone.
Good morning, my colleagues and friends. I would like to thank Dr. Huang and the conference organizers invite me to give this presentation. Today, I would like to discuss alcohol use disorder for four main reasons. The first reason is that alcohol misuse is related to more than 60 diseases, which is true in the United States as well as in China. And this disease costs about $1 trillion to the society as annual economic burden. Unfortunately, there is no sign of reduction in harmful drinking during the last years. and fewer than 2% of patients with IUD receive the medication. So this is really a worrisome situation after half a century of research. So today I would like to emphasize this disease as a composite disorder with this outline sheet for concept, ideological metaphor, and epidemiology. And at the end, I will touch base with the treatment results to demonstrate the composite nature. As a concept, we usually call AUD a complex disease. This concept stems mainly from its disease mechanism, as listed here. We will come back later to this. However, regarding behavioral phenotype, we may call this disease as a composite disorder because of 4 symptoms or more even. For example, heavy drinking, drinking frequency, relapse, and withdrawal syndromes. Which is not new, in fact, because in 1968, Bulit Haival of Norway published a paper. This is the title, the DSM-3 diagnosis of alcohol use disorders in women, finding from follow-up study of 44 female patients. And she was the first time report AUD as disorders. After then, in the PubMed, there have been about 7,000 publications using disorders. This term, mainly because of the phenotypical heterogeneity. Now, but what can we do about this? 33 years later, DSM-5 published with 11 criteria to diagnose AUD. Here I'm listing them in different order based on mechanistic understanding. Blue for needing to drink, red for implanting, and brown for desperation, which form relation as shown here. So we drink alcohol, we come back to Y, and causing implanting, and this status influence each other with desperation, which is also a consequence of implanting from drinking. Now, why drinking? Let's review obvious ideology, which is environment risk. We know historically there was a flood, 5 months flood, which happened about 1600 years after the first human was created, which is Adam. Now, if we look at the Bible, book Genesis chapter 9, verses 20 to 21, it says Noah, a man of the soil, proceeded to plant a vineyard. When he drank some of its wine, he became drunk. So this was the first report of drunkenness in the human history. The graph here, you can see, this painting shows Noah drunk, lay down, and his 3 sons standing outside, and 4 men and 4 wives, together 8 people, they survived in the big ship. Now this whole thing happened 6,000 years ago. By that time, Noah carried about 300 mutations in his genome. So it's unlikely his drunkenness was due to genetic effect. Based on those facts, I think we can agree that the environment was the reason that New York got drunk. So it's the environment. We then have a metaphor of alcohol's function, which is a soil for gravity. Because of the soil for gravity, which causes exostasis of well-being, and allostasis is biological adjustment to environment change. EX is external alcohol for internal balance of well-being. So together we have exostasis, a new word. And the green line is for calm of mind. So this cup represents a well-being of a healthy individual. And when environment factor comes in, this status is affected. But if small environment, it can be recovered quickly. However, when large environment comes in, such as the big flood, then the well-being status is affected severely. But if we drink alcohol, we can quickly get a temporal well-being or the calm of mind. And then, however, for long term, we restore the well-being status. And if we have other risks, for example, genomic risks to prevent well-being from restoration, then we have a desperation situation. During this desperation, we drink more, and which can imprint the genome further to make the things worse. So with this metaphor, we have a hypothesis, which is a different risk entice diverse drinking behavior. For example, this group of risk contributing to heavy drinking and other risks for frequency or intensity or relapse. We don't know how this happened, but we do know the composite nature. At the epidemiology level, we recently reviewed published data and found a number of correlations between drinking measures. For example, in this case, we look at percent heavy drinking information versus percent drinking days in the same group of people. And we reviewed many published studies, so each dot represents a cohort. And we found this nice correlation between percent heavy drinker days and the percent drinking days in brown. However, the correlation between percent heavy drinking days with drinks per drinking day is much weaker, as you can see from this diagram. We also look at the percent drinking day versus drinks per drinking day. As you can see, the correlation is even weaker. So those data suggest that frequency is a different mechanism from intensity. Now, we all know that smoking is closely linked to drinking, and there was an epidemiology report published in JAMA about 9 years ago. They look at the smoking prevalence and cigarette consumption in 187 countries. They conclude that the number of cigarettes per smoker per day also varied widely across countries and was not correlated with the modeled prevalence. That's important. So again, their findings suggest that frequency is a different mechanism from intensity. Now, we also look at the alcohol drinking in the more than 100 countries for the year of 2016. Here is the prevalence versus consumption. in the country, we because income influences alcohol behavior based on availability and the ability to purchase. So we divided the country into 4 financial groups: low-income country, low-middle countries, upper-middle countries, and high-income countries. You can see the correlation is weak for low-income countries, and also weak in low-middle countries, and a little bit high for upper-middle countries, and the R value reached 0.74 for high-income countries. So in the low-income countries, there is a poor correlation between prevalence and consumption. Now we also look at the prevalence versus the percentage heavy drinking episode in the 4 groups, and we found that the correlation is even weaker. So again, there is a poor correlation between different measures. So what about genetic risk besides environmental and social status? Well, during the last 20 years, a lot of work was done to identify genetic risk. When we define the phenotype as dependence, then unfortunately no genetic risk was found based on this classical paper published in 2010. Later on, people use specific measures of the disease. For example, they use alcohol use disorder identification test score. And people also look at consumption levels, and those are meta-analysis publications. And Dr. Qing of Taiwan here also contributed to this category of work. Congratulations to Dr. Qing. So collectively, 5 genes were identified as genetic risk in Eastern Asians. Those are risk more likely for consumption than for drinking frequency. Now, what are these genes? We care about function because genetic findings are statistical findings. So the 2 of the genes are related to alcohol catabolism. And KLB is a gene encoding plasma membrane growth factor receptor. And the GCKR encodes group kinase inhibitor. And the BRAP encodes BRCA1 associated protein, which involves kinase signaling. We know BRAC is a classical risk factor for breast cancer. So those 5 genes are widely expressed in the body, not restricted to central nervous system. So they are ubiquitous genes. The problem with genetic approach was the lower phenotypic resolution. That explains a little bit of the difficulty of the genetic field for studying this disease. We know that genetic approaches are limited by both the complex and the composite nature of AUD. So what about single drug treatment results? Because they can provide causality information. We have looked at those published meta-analysis. For example, Meso et al. Published 10 years ago about naltrexone camprosate, to FDA-approved medication for AUD. They look at 4 phenotypes here: abstinence, heavy drinking, craving, and heavy drinking together with craving. and for both of the drug, and we pay attention to the G column. G means effect size, and you can see that acamprosate has the largest effect size for abstinence. It has a G value 0.359, comparing to 0.03 and 0.07, 0.03, and 0.04 for other three measures. So this data set suggests that acamprosate seems to have selective efficacy. Now another meta-analysis published a year later in JAMA, they looked at three measures: percent heavy drinking, percent drink days, and drinks per drink day, and also on the two approved medicine. And they found that acamprosate is effective in reducing percent drinking days comparing to the effect on drinkers per drink day and the percentage heavy drinking day. So this data set again suggests that acamprosate had a selective efficacy on drinking frequency. Now we also look at 4 different off-labels for relative efficacy. Relative efficacy means percent reduction of the baseline levels. Here, placebo effect is controlled. We look at also the 3 same measures: percent heavy drinking days, percent drinking days, and drinks per drinking day. As you can see, topiramate is effective in reducing drinks per drinking day by 10%, but not good on the other 2 measures. Baclofen is good to reduce percent drinking days, 11%, and plazosine is good to reduce percent heavy drinking days, but not as good for percent drinking days or drinks per drinking days. Varenicline is particularly good for reducing drinks per drinking days, but not effective for reducing the other 2 measures. So this data set suggests that medication selectively treat different symptoms, again demonstrate the positiveness of AUD. Well, as a conclusion of the sheet, we demonstrate the positiveness. The purpose is for clinical precision, including understanding disease risks. For example, exostasis, and also for diagnosis, we need to pay attention to different drinking measures, including gender effect. And more importantly, to design evidence-based pharmacotreatment of this disorder. From our understanding, the information we have collected, we will propose combinational medication. For example, combine plazosine with topiramate, or plazosine with varenicline for achieving better efficacy in treating AUD. This is the end of my presentation. Thank you for your patience.
Thanks for the excellent talk presented by Professor Lin. Now we proceed to the next speaker, the Dr. Kunhong Wu from Taoyuan Psychiatry Center. He will present holistic healthcare and integrated services for patients with substance use disorders at Taoyuan Psychiatry Center collaborated with Taoyuan General Hospital. Let's give Dr. Wu a warm applause.
Honored guests, I'll try to make it as brief as possible because I know everyone is hungry right now. Me too. Thank you. I want to present you the holistic health care and integrative services for patients with substance use disorders at our hospital and with collaboration with Taoyuan General Hospital. We cover patients from Miaoli, Hsinchu, Taoyuan, and Taipei. It's about nearly 7,000 square kilometers. We have a variety of treatment models, and including case management, contingency management, spurt, screen, brief intervention, and the referral to treatment. Also, take care of subgroup care, especially people with HIV, people living with HIV, and chemsex people, and juveniles, and women. We also offer multidisciplinary training for workers. We have a collaboration with all kinds of organizations. We have various cooperation programs with other organizations. We cooperate with case intake and referral, promotional lecture, and drug offender education, and support group, treatment model promotion, and health education. This is our case flow in diverse treatment modalities for our patients. In stage 1, patients have to come to clinic every 2 weeks, and then after stabilization, for the remaining 9 months, it's about one visit per month, multimodal assessment, and multidisciplinary for 6 times. Treatment lasting at least about 12 months. We offer biofeedback treatment and group and individual therapy, individual and group therapies. We also offer patients to strengthening their reconnection of drug cases to family and society, help them return to society, and also referral to community services, and referral to other organizations, including other hospitals and NGOs. We also offer case management programs, especially for people with major risk factors. This is our comprehensive program. We also offer biological assessment, including EEG and hepatitis treatment, and HIV treatment, and other medical conditions. We offer psychological assessment using multiple tools to assess their addiction severity and refer to treatment, and also help them get HRV analysis. We also offer social assessment and referral to resources. We have diverse treatment modalities, and also treat for their comorbidities, including psychiatric and medical comorbidities. The major comorbidities are depression, anxiety, and bipolar disorder. About physiological comorbidities, including hepatitis C, HIV. We have a program, we offer coupons to incentivize patients to seek treatment. Contingency management program with special coupons. And okay, so after the collaboration, we have all kinds of resources combined to treat our patients. We have addiction treatment combined with infection treatment, family medicine, gastroenterology, and nephrology, neurology, psychological assessment, and psychotherapy. Thanks for the help of Taoyuan General Hospital. We have integrated services for patients with substance use disorders. Our major cases are from delayed prosecution treatment and methadone maintenance treatment. The severity, most patients are moderate in severity, and their quality of life improved after our treatment, and their severity of dependence decreased after our treatment. And we use BAMC, brief addiction monitor, to monitor their condition, and their condition improved after our treatments. And the retention rate in methadone treatment also increased for the recent years, and the completed rate of delayed prosecution treatment also increased. And we also follow our patients, and their days of using illicit substances decreased. And we also offer all kinds of treatments. And we help them get treatment from infection, psychiatry, and medical clinics. We offer all kinds of treatment, and the caseload increased. But last year, because of the COVID-19 pandemic, service amounts decreased, but increased recently. And the HIV positive patients are stable on treatment, around about 95%. Okay, thank you for your listening. Thank you.
Thanks for Dr. Wu's excellent presentation about the collaboration treatment for the patient with substance abuse. And now we would like to welcome our Dr. Yi-Chen Wu from Taichung Veteran General Hospital. She will present the psychiatry and the internal medicine collaboration for alcohol abstinence. Let's give Dr. Chen a big warm applause.
Professor Chen and Dr. Wang and Dr. Su. My figure is not very tall, so I walk around. Okay, not always, but some of the alcoholism patients are trouble patients. Physicians consider their poor lifestyle, so they see these patients might have poor treatment prognosis. We managed to think any new psychological or behavioral approach that can facilitate a patient to achieve abstinence. This is the topic of this section. Okay. The psychiatrists are often questioned by GI men, surgical men, already stop alcohol drinking. These patients already stop alcohol drinking. The situation include for liver cirrhosis patients who want to be in the waiting list of liver transplantation, the requirement is 6 months abstinence. However, this rule might too rigid, and during these recent years, the rules of 6 months alcohol abstinence is not so necessary. Okay. The other situation is when a drunken driver has in the compulsory treatment, the government or the road safety officers want to ask if the patient already stopped drinking. In this case, I, as a psychiatrist, feel I am a physician whose decision-making is just important as a judge in the court. However, there have already some new tools. Carbohydrate deficient transferrin, CDT, is a biomarker to assess alcoholism. Previously, the marker is gamma GT. The sensitivity and the specificity for alcoholism by CDT is higher than gamma GT. Besides, combination of CDT and gamma GT improves the sensitivity without a loss in specificity, is suggested in previous literatures. Okay. From 1,340 patients in Taichung Ventral General Hospitals, we found their average CDT is 1.76%. CDT is an indicator of alcoholism, and CDT is increased in a patient of alcoholism. CDT means the proportion of carbohydrate deficient transferrin to total transferrin. So it is presented by a way of percentage. Then the cutoff point is set to 1.7% when we have to differentiate whether the patient have heavy drinkers or no alcohol drinking problem. Okay. For the psychiatrist, GI man, and the general surgeon work together in a holistic healthcare of alcoholism. We might encounter patient who has alcohol liver disease and also have or have even liver cirrhosis. We have to learn some treatment or evaluate of hepatitis, hypocoagulation. This is often seen at patient of liver cirrhosis or esophageal varices. Then we have to, in our initial assessment, liver function, personality disorder, depressive disorder, psychosocial factors is the main factors in the baseline assessment. We have to also deal the alcohol withdrawal symptom, and we use carbohydrate deficient transferrin in this follow-up or the treatment journey to make this patient have a better monitor. Okay, the last two slides. So the team work together to deal with this main domain. One is the alcoholism patients, certain behaviors such as craving, binge drinking, loss of control when they start to drink. we psychiatrists might not able to have focused on this alcohol liver disease. However, we have to pick up some high-risky patients that might be more vulnerable to have liver problem. Some risky, some genetic vulnerability make people with excessive alcohol consumption to metabolic problem or liver cirrhosis is being is aware. Okay. And alcohol withdrawal might get severity when patient reveal delirium, seizure, diaphoresis, and tremor. And we have to pay aware to patients' personality disorder. Okay, the last slide. 开车不喝酒，喝酒不开车， and no drink and no drive, drive and no drink. Thank you for attention.
Thanks for Dr. Chen's excellent presentation. Since that, we still have some time, and we are honored to have Professor Chen to join us in this session. So maybe we may open 1 or 2 questions for the audience. Wait, please. 可以用中文，没有关系。
部立桃医院在这方面全人服务是历年来做得非常优秀。可是我很好奇，就是澳洲跟那个美国的经验，就是说非法的比如说性工作者或者是大麻在有些州跟台湾的经验是一样是非法的，那这个就很好的去预防它的成瘾。可是烟酒，至少我在台湾看到的部分是我看到很多长相其实。他高头大马，但是他可能还不到合法的年纪，那他很容易就去取得。那关于chemsex 这个也是合法的，那这样子要怎么样在及早的预防，避免他的成瘾，然后以至于我们必须负担很大的医疗来收拾。
谢谢您的提问哈。那请问您的专业背景是？如果方便的话，哦，新美教好，你好。对，那我个人其实门诊接触到蛮多，您提到那个药爱啊哈，就是还有各种物质成瘾哈。事实上我蛮同意您提到，就是其实合法的物质成瘾比非法的造成的情况是更严重哈。我们在门诊看到个案蛮多样化的哈。那我个人觉得最好处理的反而是1级的物质成瘾，就是那个海洛因鸦片类的哈，因为现在有很好的药物可以治疗。那他们的因为法律也蛮重的，所以他们也愿意配合治疗。那在司法跟这个卫生的帮忙之下，这些个案就得到很好的控制哦。他们的 C 型肝炎哈，就大部分都得到治疗，艾滋也能够很好的追踪。那这在以前是难以想象的哈，所以我觉得这是台湾的一个公卫奇迹之一啦哈，就是在这个2006那时候那个 HIV 大幅上涨，那感谢就是像郑淑欣副院长还有陶医的团队给我们帮忙哈，那我们可以把这个疫情快控制下来。那推广到烟酒的部分，我个人的想法是，如果烟酒的部分哈，我们可以再多一点力气哈，例如说我个人想到的一个很好的切入点是那个危险驾驶啊哈。就是大家现在都很重视酒驾的问题，喝酒不开车嘛。但是往往酒驾的人到出意外、致死然后重伤被抓到的时候，他或者被抓到酒驾送到监狱，他之前已经酒驾非常非常多次，他危险驾驶已经非常非常多次。那如果说我们可以利用危险驾驶，然后这个他可能被记点、被吊扣牌照，那要再申请驾照的时候，需要有一些健康的检查，这样检查包含这个心理的评估， 或生理的评估，他到底适不适合开车？因为开车其实是一个特权的并不是天赋人权，所以他有好的开车能力才能够保障人权，才能够保障自己还有其他用路人的安全。那如果这过程中我们可以有好的处理的话，可能就可以把很多有精神问题或者物质成瘾问题或身体状况不适合开车的人，就可以有一个处理这个包含机车汽车，甚至脚踏车都可以。那这个是我觉得可以处理合法问题的一个途径。另外就是如果可以的话，像烟现在有很好的一些治疗补助那酒的部分这部分还比较缺乏这个的确需要大家一起努力看是不是有相关的资源。我能想到是说可能看可不可以有酒捐捐的话才能够指定用途嘛，税的话是不能指定用途。那另外就是相关的饮酒造成的一些这个社会损失，那个应该要有负责，要有一些罚款要有一些罚款可以运用在相关的治疗防治方面那这样的话可能可以降低这个相关的风险。另外我现在看药酒瘾，我也蛮常推广，就是请他们一定要买个酒测器自己测一下自己测到再上路总比说被警察自己测一次酒测器一次的成本大概1块钱台币，被警察测一次大概8万10万以上跑不掉或关半年这个蛮多更好应用，那也希望再慢慢推广这样的一个概念另外其他那个chemsex 或者是其他的大麻那些所谓的软性的药物，其实软性是推广的人讲的，其实它真的用起来那个危害有时候反而不见得输给那个所谓的硬性的成瘾物质这边可能还在需要更多的卫教。另外我觉得最好的替代疗法像我们海洛因有这个美沙酮替代疗法，有丁烯片替代疗法，那其实这些药爱这些软性的物质咖啡包等等他们寻求就是一个快乐一个抒发。所以其实我个人觉得最好的替代疗法其实是快乐替代疗法，有正向的快乐来取代这个负向的快乐像我现在有同学很喜欢跑步跑马拉松，那跑久了其实他一天不跑反而是很痛苦的事情那我们会不会说运动成瘾？不会，因为运动是好的一个状况像早上听到执行长他骑脚踏车得到第3名这个很厉害。那跑步真的会蛮不错的我最近慢慢养运动习惯，那运动会让你的脑内啡增加这是比较高级的一个酬赏，用好的酬赏取代不好的酬赏。那他们用物质成瘾，大部分是追求的是那个多巴胺或者正肾上腺素，这也很快，但是也很快就会产生耐受性所以可能就是我们在生活上可能要推广工作和这个生活的平衡提供一些好的正向的娱乐这样那如果有一些资源可以帮我们的青少年小朋友有好的娱乐，就是不要只重视数学国文其实运动然后一些好的娱乐培养，让我们的可以快乐的生长快乐的人做什么事情都会比较快乐，比较容易成功，那赚的钱其实也会更多并不是反之，就是大家会觉得说我们赚钱之后就会快乐，其实相反，是你快乐的人做你喜欢的工作做得好，才能够赚钱，然后赚钱更快乐，然后也愿意帮助别人，这样会有一个社会一个正向的循环好，这是我个人的浅见谢谢大家，谢谢。
好。非常谢谢吴主任的回应。那我只稍微补充，确实是要跨领域的合作。那所以甚至于我们还需要到校园里面及早教育小朋友，避免这样的问题。好，那因为时间关系，我们非常谢谢我们在座所有的专业伙伴跟我们的这个同仁以及我们现场与会的贵宾。那我们是不是给自己一个热烈的掌声？那我们就结束今天的 session。谢谢大家，谢谢。
感谢专家带给我们的精彩演讲。接下来为用餐时间，这边提醒各位贵宾，以下有2点事项宣导。
Before the lunch break, we have a few reminders.
首先，与会人员证上有满意度调查表的 QR code， 午餐将凭满意度调查表完成画面以及餐券至入口处领取午餐，并移至第5会议室群楼1楼用餐。
Firstly, there's a satisfaction survey QR code on your conference badge. Lunch will be provided at a service counter located at the entrance upon presentation of proof of completion and the meal voucher. Please proceed to conference room 5 or the first floor of Chuying building to enjoy the meal.
第二，大家可以利用休息时间到桃园疗养院 B1 阶梯教室逛逛身心灵市集，也可以在今天上午11点至下午3点凭与会人员证至门诊大楼1楼室外草皮免费领取无忧生活 U 等于 U 的咖啡。
Secondly, during the break, you can explore the Mind and Body Wellness Fair at the B1 level classroom in Taoyuan Psychiatric Center. Additionally, from 11 o'clock to 3 p.m. today, By presenting your conference badge, you can receive a complimentary coffee free U equals to U coffee on the outdoor lawn on the first floor of the outpatient building.
再次感谢各位贵宾的莅临，愿大家在今天的论坛有满满的收获，预祝各位论文发表顺利，谢谢。
Once again, we thank all our distinguished guests and attendees for joining us today. We hope that you will have a productive and rewarding experience during today's forum, and we wish each presenter a successful paper presentation in the afternoon. Thank you.